Hello and welcome to my channel, Silver Lining. My name is Peter Abraham, a registered nurse. Just wanted to give a follow-up video for the episode that was talking about resources for hospice nurses. This episode is not just for hospice nurses, but RNs, LPNs, med techs, family members who want to learn more about comfort medications in hospice. So I do want to dedicate this video to several of my colleagues. There's Nurse Amy that lives in the, um, oh my word, I came from that county, Lancaster County. Sorry to take a moment, Amy. Who I mentioned in the previous episode wanted to have more information about being comfortable with meds, not only for herself but other nurses. She works in the PCU. She came from many years of med surge. I have Ed, Nurse Ed's a hospice nurse out in Texas. Nurse Tonya, a hospice nurse out of Georgia. So just want to acknowledge I have a number of nursing colleagues that I look up to each and every one of you in one way, shape, or form for different reasons, and I believe collectively we can lift up and encourage one another. So before I go too far on talking about morphine and lorazepam and so on, if you have any questions about the content, whether it be nursing or end-of-life care, hospice, um, healthcare-related topics, book writing topics, comment. I mentioned in previous episodes, I certainly don't know it all, but if I'm able to help you, let us help one another. And if I answer your question and you think it's garbage, you're not going to hurt my feelings. But maybe we have some dialogue and we learn from one another. Um, with my years of hospice, I have uh, the understanding that oxygen at end of life can cause more harm than good depending on the circumstances. But one of the things I didn't know was that if you did not need oxygen at the end and you got oxygen, you might be increasing the discomfort level due to anxiety and agitation. And that piece of knowledge came from having a conversation with Nurse Tonya earlier today. So thank you, Tonya, so much. I do appreciate you and the discussion that we had. And we were talking about hospice comfort meds, so it kind of fits into this video. But I do want to share some experiences of why I have no fear for the amount of comfort meds I give, especially in a crisis situation. So one of the early crises that I faced in my in hospice, and it was within my first 2 years of hospice. That's when you're first, like, if any of you know nursing theory, and I apologize, I forget the name of the actual theory, but there's a theory out there that you don't get comfortable in your own skin within the field for anywhere from 6 months to a year or two. So I was within that zone of what don't I know, and that discomfort level. And I had a patient. I'm gonna say his name was Greg, home patient, esophageal cancer. I did write about Greg on compassioncrossing.info, compassioncrossing.info, under the title of Fate Stories in Hospice. And that was a story that came out from Nurse Catherine, one of the people I know remotely as well, who asked a question about can you have faith in hospice. Is going to lead into the comfort meds. But Greg, esophageal cancer, wife was at home during my visit. If you're the wife watching and you're listening to this, you might find something that's distressing. Feel free to comment, and we can reach out and have a discussion. Not that you're going to get it. I'm not relieving, kind of phrase. I'm not giving out HIPAA information, but there are times where somebody personable might go, that could be that person, and maybe you were that nurse. Talk to me. So Greg, esophageal cancer, rather young patient, asked me to kill him. which, by the way, I didn't. That's not the discussion of the comfort meds. But here, long story short, we're both bawling on his sofa. I can't do it. Nobody, he's saying nobody's going to know. Well, I serve a God who is all seeing, all knowing. He will know. And even if it is never found out, I could not live with myself with doing that. But long story short, Greg lost his airway. And that was the first case of palliative sedation. So if you're watching this video and you've never heard the words palliative sedation, it is not euthanizing. It is not physician's assisted suicide. It is not medical aid in dying. Now, I do take great offense by using the words death with dignity when it refers to those topics, euthanasia, physician's assisted suicide, medical aid in dying, because all of my patients who died naturally died with dignity. Their dignity was not stolen from them because they died naturally. But I could not go forward with this with Greg. We had a conversation about that in tears. One of the few times I was crying with and in front of a patient, and I'm not ashamed of that. There are times where we have to let everything come off so that our patient sees us as fellow human beings too. That is very critical in certain situations. Not every situation, but certain situations. Well, Greg ended up losing his airway. And that was the very first case of palliative sedation. Now, palliative sedation is legal in all 50 states of the United States of America, and that is with doctor's orders, the intentful sedating to a level that the person may not wake up again. Now, under normal circumstances, we don't want them to wake up again. That wasn't this particular case. This was a case of we need to keep them comfortable. Loss of airway, outside of hospice, medical emergency, intubation, etc. In hospice, we're not intubating. This was DNI, DNR. Palliative sedation. So with Greg, and I'm just pulling up, I do have a techie geek, whatever you want to call the nerd. So I have a database where I keep track of, like, if you have this symptom, it's my own symptom management tracking system that goes above and beyond. This red book, Symptom Control in Hospice Care by Peter K, if I'm pronouncing his last name correctly. So this is a wonderful resource. I did get this used on Amazon because it can run $150 or more for the most recent version, and stuff doesn't change that fast when it comes to what's written in here. So I do recommend this book. But you're not going to find everything in that book, and that was this case for palliative sedation. We're working with Dr. Barr, wonderful, wonderful physician, and a personal colleague and friend, at least from my perspective. And for Greg, in less than a 2-hour period of time, 160 milligrams of morphine. We're doing 20 milligrams of morphine every 10 to 15 minutes. We did 8 milligrams of haloperidol, and I've had cases where we used a lot more. So there was, and 4 milligrams of lorazepam, which is Ativan. All that within a 1 to 2 hour period, just double checking my notes for that cocktail. We used a similar cocktail for a person who had a GI bleed that was having the worst case of terminal agitation that I personally witnessed. That was towards the end of year 2. It was a bowel obstruction and a GI bleed on top of that. And in that case, the cocktail was very similar, but it was 45 minutes. Greg took a little bit longer with the lost airway. For those who don't want to go to the website to read the story about how you can have faith and operate in faith, I'm not talking proselytizing or crossing boundaries, but the gentleman who wanted me to kill him, who we ended up doing palliative sedation. His was a form where we were monitoring every single day. Would he regain his airway? Low percentage chance. But we serve a God, for those of you who follow Jesus, and I'm not trying to preach on this channel, but if you follow Jesus, he walked on water. God parted the Red Sea. Even though no one expected his airway to come back, it did. And I'm going to get back into the morphine Ativan story shortly, but to me this is relevant. Uh, his airway came back. And we're still visiting daily because this is a sensitive situation. He's going to lose it again. We're going to have to go to route of palliative sedation. And so I was the nurse going every day. I pulled weekend duty that weekend. Lost his airway. I believe it was a Wednesday. He asked me to kill him on a Monday. That Sunday, I'm at his house. It was an unbelievably long day. I don't want to go over too much in geography for where I was serving because I do want to be careful with the HIPAA, even though I'm using an alias. Not for me. But I go there last like 6, 7 o'clock at night. It was that long of a day, starting very early. And families gathered around. And I'm a geek, I'm a nerd. I don't know sports from the back of my hand. You know, you told me they made a touchdown. Now at 61 and a half, I know what a touchdown is, but a couple of years ago, you might as well have told me that I don't even know how to give a comparison, but they were on, you know, both TVs, first floor, second floor, you know, all the sports game, lots of family present. Greg's up on the second floor in his regular bed. Not everybody has to be in a hospital bed. And he's in and out of consciousness. And I do my visit, you know, making sure they have enough meds for everything, making sure he's comfortable. And I go up to say my goodbyes. I'm weird. Hopefully it's weird in a good way. But to me, the humanity of what I do cannot be replaced by anything. And I always want to treat everybody with dignity and respect. And that includes when possible, and hello, and when possible, goodbye. So in this case, I'm going up, and I feel, to me, this was a miracle, for lack of better words. Greg's in consciousness. He's awake. And he's watching the game. And I lean over in a whisper. I lean over and say my goodbyes, and then I said to him, because I checked in with the different family members, everybody gave their goodbyes, their permission for him to die. Greg, you can go now. And he looked up at me and he said, I want to see the end of the game. And the moment those words came out of his mouth, we both realized what he said, because that Monday he asked me to kill him. And we both broke out laughing our heads off. Obviously, he wasn't laughing too hard. He's dying. But he's laughing, I'm laughing. I'm kind of glancing over because I never told the family. I did, communicate his request to our team and took appropriate measures. You have to consider suicidal ideation. That was ruled out. And it didn't happen that way. But I leaned over after we got done laughing. I said, this is on you now. And that Monday morning, 1 or 2 o'clock in the morning, I was still on call, got the call, he passed away. So I was the nurse who went and pronounced. But this was a gentleman, getting back to this ties into the morphine as well. He got to see the end. Had I killed him, he wouldn't have got to see the end of the game. He had a higher quality of life because he died naturally. And God works wonders, always. But in terms of the morphine, for that palliative sedation, 180 milligrams of morphine in 1 to 2 hours. Another person, a 72-year-old, similar cocktail in 45 minutes. And how I had no fear with this really started in the hospital setting when I worked in cardiology. So one of the areas that my coworkers at Harrisburg Hospital, 7th floor, yay, Main 7, noticed that I didn't notice. I was a nervous Nelly. It was my first job, hospice. I'm in my mid 50s, and all my coworkers are in their young 20s and early 30s, and they're zipping around like crazy. And I'm like, gee, am I going to be able to keep up with them in my 50s? And so here I was getting more and more hospice patients. Now this was a cardiology floor where people went to go, they got tests like get an echocardiogram. They may have some, stent procedures. It was part med surge. My youngest patient was an 18-year-old pregnant lady on med surg, not for cardiac reasons. But most of the patients, they were relatively stable. But every 4, 6, maybe 8 weeks, we'd get a hospice patient. And more, I'd come in for my shift and they'd say, Peter, you have so and so. They're on hospice. They're complete care. You're their nurse and their CNA. You're everything for them for their shift. And I don't mind any of this, but I am curious. I love asking questions. I'm not as good as my wife with asking questions, but I ask, without being offended, like, why me? I don't mind, but why me? And they said, Peter, you seem to have more patience with not only the patient themselves, most of the time they're not interacting. When you have hospice in the hospital, they're typically severe cases. They're typically in their last hours to last few days of life. But you have the family members and the friends coming in asking lots of questions. And I would take the time to answer those questions. And I wouldn't be like this or watching the clock. I would be looking them in the eye or going to an area where we could sit down quiet and I'd listen to their concerns and we'd have a conversation. And maybe it's my age group, maybe it's the I'm an introvert, maybe it's because my grandmother raised me or I grew up in coal mining country. I don't know. Maybe I'll just thank God I have patience. And with the comfort meds, one of the hospice patients I had was wasn't my first time doing a morphine drip, but my first time doing a morphine drip on a hospice patient. So I had to set up the morphine drip. That's IV. High risk medication. There are 2 nurses need to set it up. This is not how many nurses are needed to change a light bulb. This is high risk. I set it up. I'm getting checked off by another nurse, and I would, if another nurse is doing it, they might call me to go in and check on their work. Dosage calculations, the whole 9 yards, 100% on target, high risk med. And so we got set up, started the IV morphine. I try to be transparent in everything. I don't remember the starting dose. I don't remember the ending dose. What I do remember is the doctor's orders were that every 30 minutes I had to assess this patient, and if the respirations were above 24, I needed to bump up the morphine. Every half hour, I had to do this. Now, when he first came in, this was evening shift, 3 to 11. He first came in, his respirations were in the low to mid 50s. And after 8 hours, I increased the morphine 16 times. Don't have enough fingers for 16. 16 times. Every half hour, I increased. So at the end of 8 hours, his respirations were in the 40s. And I'm doing my end of day charting, so it's past 11. If any of you are wondering, if you work in the hospital environment, do you ever get out on time? Rarely. That's okay. If you love what you're doing, it works out. 16 increases. I'm doing my charting as I'm doing the increases, but at the end of the day, I'm summarizing. and I'm getting ready to give report. And my night shift nurses are coming in, and my fellow coworkers from evening shift I must have looked like a deer within the headlights, and my mouth on the floor unhinged. Like, Peter, what's wrong? And I'm thinking to myself, and I said out loud, I said, over the past 8 hours, I increased his morphine 16 times. And they look at me without blinking an eye. And? Well, at the rate that it didn't lower the respirations, night shift is, they said, yes, Peter, night shift's probably going to increase it another 16 times. And if he's with us in the morning, day shift is going to increase it another 16 times. The maximum dose of morphine is high. It's extremely high. I have had coworkers who had patients who tried to kill themselves by taking the entire bottle of morphine. I don't know how not that I don't know, I have how to phrase. I've had people tell me the taste of morphine is awful. I have no idea. I don't sample the product. So I don't know how they managed to not throw up what they did. But a bottle of morphine that you get from a pharmacy is 30 milliliters. That's 600 milligrams of morphine. The maximum daily dose of morphine is 1,600 milligrams. I do have to give a side note. Nurse Ed, if you're watching this, I agree with you, just to reemphasize. Nurse Ed, contacted me a day or two after I shared in one of my end-of-life, I shouldn't say one of the end-of-life forums I participate in, where I was trying to calm a family member down, where, the hospice agency gave like 5 or 10 milligrams of morphine. Is my son having a toxic reaction? It's like, maximum daily dose is 1,600, and Ed's coming in. And I'm thankful, Ed. So this is not a negative that Ed jumped in and messaged me. According to hospice doctors, there is no toxic level. And Ed is correct. Ed, you're correct. I agree with you. But in terms of like when we talk to one another, nurses, and we talk to family members, I do believe we need to have certain landmarks so we can say, you weren't that close to the edge. Out of nursing school, I was so blessed by God that my wife and I were able to go to Ireland. And it was my treat to her because I did not work my first semester in nursing school. I was at 30 years out of school. She was gracious enough to not only work full time, but pull in extra hours and do a lot of overtime to allow me to not have to work that first semester. I did work, the after that, but only part time. And this is my way of just saying thank you so much for putting up with me during this time period. Lots of tears, everything else. And we went to Ireland. And any of you who have ever been to Ireland and you go around the Ring of Kerry, the locals know that under certain time periods you drive clockwise, and other times either you drive counterclockwise. Well, non-locals don't know that. And we're in our tour bus, and the driver's local, so he knows what he's doing. And but we had a car coming the wrong way, and he's backing up for the car, and we literally were that close. If like within, I wouldn't even want to get out of the bus to measure how close we were to going the back end off the cliff. That cliff was a landmark. And I like to be able to show families as well as fellow med techs, whoever's giving the meds, here's a landmark, 1,600 milligrams. Here's the doctor's order, 5 milligrams every 2 hours or every 6. I've had cases of giving 20 milligrams an hour. I had a pancreatic cancer patient getting 40 milligrams an hour. We work with the local pharmacy to compound that medication. So instead of the normal 20 milligrams per 1 ml concentration, it was 40. So the wife could give 1 syringe versus 2 every hour. And that wife faithfully 24 hours a day. She was exhausted towards the end, but faithfully every hour was giving her husband pancreatic cancer, one full syringe, 40 milligrams an hour. That's 960 milligrams of morphine for the entire day. How's that compared to 1600 milligrams? You still have 640 milligrams to go. And again, agree with Ed. The toxic level is just a point on paper. Right now, we're focused on comfort. Right now, we're focused on comfort. And if you have a loved one in crisis, and maybe they're not your loved one, maybe you're the med tech, the LPN, the RN, whatever your title is. I'm not a big title person. I want to respect everybody. And I've had people who have lesser titles than me know more than me and teach me things. Everyone matters. So I always try to look at it, this is could be my loved one. I'm going to have professional boundaries, but I don't want them to suffer. One of the things I love about hospice is most of my patients are DNR. That doesn't mean that I'm trying to hasten death, but it does take a burden off of me that if in my goal to make them comfortable, if they die, with the understanding I had no intent to do that, and I have doctor's orders, and everything's within the pharmacokinetics, etc., I can sleep with that because they went peacefully and comfortably. And I'm not promoting, if you're watching this, because I've also had family members say my nurse sneaked my loved one some morphine, and I'm so happy they did. If you're watching this, I am not talking about that whatsoever. I'm not going to take a side on that. That's not me. I'm going to follow doctor's orders. I'm not sneaking. I'm communicating. And I'm sharing this is what we're going to do. So all in the cases that I've ever been involved with for palliative sedation, for example, and there's been a number of cases, everything was clearly communicated. Doctor's orders obtained, communication provided, including the impact. If you watch episode 1, I went over the question mark, was I let go because of ageism, where I stand on COVID vaccines, I'm an unvaccinated registered nurse, or was it because I was advocating too strongly for a lung cancer patient who asked for palliative sedation? And so I educated, if you're sedated, you're not going to be able to eat, you will go faster, but it's not the meds, it's the disease process. So when you're going to the doctor and saying, what can you give, you have a lot of leeway. Now, in a future video, because I'm just looking at the recording time here, I can go over, and it's a clinical estimate. How do you know how much to ask the doctor for that's within parameters that they're most likely to say yes to, that will help the patient be comfortable with the least number of attempts? That stated, I'm going to tie this in. I suck at inserting IVs. I'm not horrible if you're not dehydrated. But if you're dehydrated, I'm going to try once, but if I don't succeed, I'm asking somebody else because I don't want you to suffer. So when you're talking about somebody who's in a crisis situation, I'd rather overshoot within a safe parameter than undershoot where I have to keep coming back, because not only are you going to be ticked off at me, if you're somebody that's dying, it might be that they're not knowing that it's me not getting, I don't want to say getting it right the first time, because there's not a science. There's not a textbook that's going to say, if you see this, give exactly that. It's a clinical judgment. But I'd rather overshoot within a reasonable parameter than undershoot and have to come back and explain to the family, we didn't get it right, we didn't get it right, we didn't get it right. To give you one example before we close, and this is also an example that, hospice doesn't forbid you from calling 911, and sometimes we're actually involved in the calling. So late last year, around the time of Thanksgiving, and I remember this for a number of reasons, including I was precepting a nursing college student, a senior York College. Loved doing those precepting, and I had a CHF patient come in. And this is one that gets back into like knowing your eligibility, but also knowing when to fight when the area is gray. So they were not New York heart failure class 4, but I had evidence to present to the team that within less than 2 weeks they would be. And they were. It worked out that way. They came on board. They had a liter fluid drawn pre-hospice, came not on oxygen. That's why they weren't New York class 4. But they went into crisis. And they're on oxygen at this point in time. They're in crisis. I've given what the doctor's orders were, and they're still in crisis. So I asked the patient, here are options. I'm listening to their lung sounds. I literally heard as if you were rubbing a rubber duck underwater. That's what I heard, a pleural friction rub. It literally sounded like underwater. I could tell that fluid was building up again in the pericardial area. And I said, I can't drain this at home. And he was having a panic attack due to air hunger. I said, here are options. I can call 911. I will stay until they arrive. I can call 911 because we've maxed out the doctor's orders that were there. Or I can do my best to do palliative sedation. What do you prefer? He wanted to die at home. Let's palliative sedate. So I called the doctor. Now the doctors out there for hospice, the majority of them are good. I like to err on the side. The majority of them are good. But you're going to have the conservative doctors, and when I'm a conservative when it talks fiscally, but when it comes to end of life, I'm liberal, meaning that I don't want to euthanize, but I want them comfortable as soon as possible, and I don't want to mess around with their comfort. This is their comfort, not mine. This is them, and they matter more than I do, and they matter more than any value I have. But some of the doctors are out there, they don't want to be Dr. Kevorkian, and they're unbelievably conservative. And not all of them are accepting of the education that we try to provide as hospice nurses. And there's good and bad to that. You do need somebody to put on the brakes. Because what if a nurse was too liberal and was crossing the line? So you need that accountability. But in this particular case, this was a doctor where you start off at 5 milligram increments, and 20 milligrams. Let me put it this way. One of the doctors I work with, if I wanted to do 20 milligrams of morphine every 5 to 10 minutes, and I can present my case, the answer is yes, and I got signed doctor orders. This doctor, I feel blessed if I got up to 20 milligrams an hour. And sometimes that's enough. But for palliative sedation, it's pushing it. So we gave the 20 milligrams of morphine. We gave a milligram of Ativan. And my parameters was I had to wait an hour. I waited an hour. The patient's panicking. We're hour 1. Call the doctor back. Do it again. Did it again. Hour number 2, and by hour number 2, I'm asking the patient, I can't tell you when this is going to kick in. Because remember back when I started this, I shared for the one patient it was 180 milligrams of morphine. Right now, because I had leeway for the first to give 10, right now we're at the 50 milligram mark. I'm 130 milligrams shy. And with this agency, we didn't have the Haldol on top of that. So he opted to go 911. I called 911. who 45 minutes later arrived, and then I had to argue with them to take him because they were focused on the vital signs. The pulse ox, 93% or 98, no, I'm sorry, it was 98%. Why do you want to take him to the hospital? Here's my stethoscope. Listen to his lung sounds. He's tachypnic. He's in the 30s. He's tripoding. He wants to go to the hospital. Are you going to take him? And I had to advocate for that. He went to the hospital. Sad part. Refused treatment. Came back. Died a few days later, and I was a nurse who pronounced. Didn't palliative sedate. But it takes a lot of these meds to intentionally cause harm. So if your heart is for the patient and providing them comfort, you do want to check for toxic reactions. Myoclonus can be a common reaction. And the lady in the hospice forum that was talking about the 10 milligrams of morphine did bring up the jerking, the myoclonic reactions. So you do have to watch, gee, do I have to go to hydromorphine? Do I have to go to another med? But if you're crossing your T's and dotting your I's and watching those side effects, and you're focused on comfort, and you're realizing that this person is DNR, and you're not hastening death, you're focusing on the comfort mark, their comfort, it's very hard to go wrong. And that's one of the reasons where I will end why I love hospice. Because I get to focus on their needs to the best of my ability and try to work with the team to make them as comfortable as possible. Thank you for putting up with this long video. Thank you for your time. If you like this content, please subscribe. Hit the like button. Please feel free to ask questions. Thank you. Have a Merry Christmas and a Happy New Year. God bless.